here in the Bathinda, and so thank you inviting me to deliver a talk on really a tough topic of gestational diabetes, because it's a topic of dispute most of the times, because still we are in the period, should we screen all the females, what should we do, should we treat them, for how long we should follow the MNT therapies, what about the metformin, glyburide. So it's a very big topic, I can say. So the time which was given to me or assigned is just 15 minutes, and I will try to put all those things in those 15 minutes. Thank you. And आगे कहाँ से करना है बेटा? This. Okay, so the incidence of gestational diabetes is rising, and why it is rising? This is because of the parallel rise in the prevalence of diabetes per se. So during pregnancy, the maternal hyperglycemia must be avoided by all the means. By all means does not mean that you start doing other things which are not being like approved. By all means proper nutrition, physical activity, and the drugs, and mainly the insulins. Aside from the short-term maternal, fetal, and neonatal consequences which are associated with the GDM, long-term consequences for both mother and child are there. Now we have got two trials by the name of MITI trial and MIG TOFU trial also. So they followed the children till 9 years, and they have found that those children in like mothers, when they were not fully controlled with the diabetes, and even those children who were put on metformin, mothers put on metformin, the children were slightly obese at that age of 9 years. So pharmacotherapy of GDM for tight glycemic control is needed to reduce the adverse events in the fetus also. So this is how we usually classify. I think the slide is not very much clear. It is the hyperglycemia in pregnancy, which usually dividing into the two parts. That is a pre-existing. If it is already there, that could be the type 1 diabetes, type 2 diabetes, or other variety of diabetes. If it is first time detected during the pregnancy, then it could be either overt diabetes or gestational diabetes mellitus. And all those things we label under one category of DIP, that is diabetes in pregnancy. Now we divided gestational diabetes into two parts, early GDM and the late GDM. Early GDM if it is occurring in less than 20 weeks of pregnancy, late GDM if it is occurring after 20 weeks of the pregnancy. So now in 2019 IDF they say 1 in 6 live births whole of the world, and in Southeast Asian countries 1 in 4 live births, they are being that is a cause for hyperglycemia in the pregnancy. And total 70 to 80 or 80 to 90% of diabetes in pregnancies is because of the GDM per se. So this is what are the metabolic changes which happen during the pregnancy. We know that there is an insulin resistance, and this is going to increase over the period of time. After 20 weeks, there is an exponential rise in the insulin resistance because of increase in the secretion of placental hormones, mainly the HPL, HGH, leptin, prolactin, and cortisol. But all the females, they don't become diabetic. So diabetes happens only once the beta cells starts failing, and they produce lesser of insulin because of the excess fuel supply which they are getting. That is the reason once the insulin start decreasing after 24 weeks of the pregnancy, the sugar start increasing and the lady become diabetic. So there is a decreased insulin production which is very common, and this usually happens after 20 or 24 weeks of the pregnancy, and that is the reason 24 weeks of the pregnancy is the ideal time, they say, to be screened for all the females to look for the diabetes. So if you took for the all the things in the parameter, whether they are genetic, whether they are environmental, whether they are using ethnicity or histories, obesity or gene polymorphism, the major thing is the etiology of gestational diabetes is because of the beta cell dysfunction, insulin resistance, neurohormonal dysfunctions, increased secretion of leptins, pro-inflammatory cytokines, as well as the oxidative stress. Now, why should we worry? It is not only that the physician should worry, we should worry not only for the mother, we should worry for the fetus also. Not here, it goes up to the newborns also, and if you follow the newborn till the adolescent or the childhood adult, so we should follow these kids. And that is the reason even the child or adult, if their mother is not controlled, well controlled with the diabetes, chances of obesity, type 2 diabetes, and the non-communicable disease in the form of cardiovascular diseases, wheezing, arthritis, attention deficient disorders has been seen in a older age group also. So mother, we know that there is like mother chances of preeclampsia, hypertension, preterm labor, decay, worsening of microvascular diseases, mainly your retinopathy, it happens, and there is a future risk of cardiovascular disease, and this risk is proportionate to the degree of hyperglycemia. And for the newborns, always rule out hypoglycemia after the birth, hypocalcemia, hypermagnesemia, polycythemia, preterm labor, or the respiratory distress syndrome which happens. Now a recent concept is that of the transgenerational concerns. What do you mean by the transgenerational concerns is, if the hyperglycemia happens at that time when the fetus organs are being maturing or they are being formed, it leads to the permanent change in their structure, physiology, and the metabolism. So that is being responsible for development of non-communicable diseases later in the life. So हमारा काम तब नहीं शुरू होता जब बच्चे को बीमारी हो, हमारा काम तब शुरू होता है if the mother is having sugars, we have to control those sugars very well from the day one, rather than saying कि 15 दिन बाद आना या 20 दिन बाद आना, we will see to it. Now again a paper given by my colleague Dr. Gagan and Dr. Sanjay. So they say preconception optimization is very essential, and they have found that if the HbA1c increases right above 6, not 6.5 even, which is a goal, if it goes below 6, above 6, the chances of developing complications, they are on the higher side. So preconception, you have to optimize your sugars level, control of sugars, weight, blood pressure, start insulin even before you think of like you are going for a family way. Discontinue all the teratogenic drugs. You can start with a folic acid, and you should screen for all the complications. So higher the periconception HbA1c, greater is the risk for the fetal anomalies. Now the main question is when to screen, who to screen, and how to screen. So this is again a big question mark, because there are different societies. There is ADA, there is ACOG, there is a FOGC, our ESI, RSSDI, DIPSI. They have, every society has given their own say guidelines ki how to screen and what to screen, and still it is slightly confusing. Indians, we follow the DIPSI guidelines which are updated in 2023. So when to screen? First, antenatal visit for pre-existing diabetes, or if we are suspecting early gestational diabetes. Otherwise 24 to 28 weeks or earlier if the risk is high for the gestational diabetes. Now to whom we should screen, whether it should be a universal screening or a high risk screening. If we talk about the high risk, this is usually age above 35 years. If the female is obese, overweight, past history or of PCOS, family history, history of IGT, GDM or macrosomia, excess gain of weight during pregnancy, poor OPS history, medications, or belongs to the high risk ethnic group. Now the question is, only these females we should screen early, or we should screen all? Again, it's a big question. Universal screening, there is no clear cut guidelines on the universal screening also. Now how to screen? So should we go for a single step or should we go for a two-step? Initially we used to say first you do the GCT. If the GCT is abnormal, then you can go for the OGTT with the 75 gram of the glucose. So there are so HbA1c, which we usually don't do much during pregnancy. There are the limitations because of the high RBC turnover. Now different societies have given the different guidelines. The Western societies are following this IADSP guidelines. They say screen during the first trimester. Diagnosis is overt diabetes if the fasting plasma glucose is more than 126, 2-hour plasma glucose more than 200. If random plasma glucose 200 plus symptoms and the HbA1c is more than 6.5. But if fasting is less than 92, then you screen at 24 to 28 weeks with 75 gram of glucose. If fasting is between 92 or 125 or HbA1c lies between 5.7 to 6.4, then it fits into the category of gestational diabetes. Then you can screen right away with the 75 gram of glucose. But this seems to be a little, you say, cumbersome process. The DIPSI has come out with the very beautiful one line that all GDM can be diagnosed if 2-hour post-glucose plasma glucose is more than 140 with 75 gram of oral glucose to be dissolved in 300 ml of water given to a lady irrespective of the fasting or the non-fasting state. ये बहुत इंपॉर्टेंट है. आप दिन में कभी भी एनी फीमेल कम टू योर ओपीडी क्लिनिक, यू कैन डू दिस व्हाट वी से द जीसीटी और द ग्लूकोज टॉलरेंस टेस्ट. सिंपल यू गिव 75 ग्राम ऑफ द ग्लूकोज. एक ही सैंपल लेना है आफ्टर 2 hours. इफ द 2 hour वैल्यू ऑफ द प्लाज्मा ग्लूकोज इज मोर देन 140, then you label that lady is suffering from GTT. And they have, DIPSI has given the 2 glucometers. One is with the AccuJack glucometer Performa and one is the Roche, one is the active glucometer, because they are being calibrated to check the plasma glucose. Number 1. Number 2, the question is, क्योंकि वो बड़ा थिक हो जाता है, like 75 gram of glucose. If the lady vomits out, what to do? If the vomitings happens after 30 minutes of intake, मान लो उसने 11 बजे लिया, पौने 12 बजे उसको vomiting आ गई, continue with the test. No need. If the vomiting happens within the 30 minutes after intake of the glucose, then abandon the test and repeat the test very next day. This is how we usually proceed. So DIPSI has given ideal screening times for the GDM. They say first screening to be done as early as on the first antenatal checkup visit for a checkup, if it has not been done preconceptionally. Second screening at 24 to 28 weeks and third screening in 32 to 34 weeks. हमें बार बार स्क्रीनिंग करने की ज़रूरत क्यों है? इसी करके है, because to avoid the fetal glucose steal phenomena. So advantages of DIPSI: it is being simple procedure, easy to execute and implement, cost effective, and it reduces your perinatal morbidity and mortality also. This is about the HbA1c. I am not going into detail because of the shortage of the time. They say if A1c is high, chances are large for gestational age, preterm birth and neonatal ICUs are on the higher side. These are the simple 3 case scenarios. A 27-year-old lady with 26 weeks of gestation, 75 gram of OGTT, 97, 185, 169, diagnosis is GDM. 32-year lady, first antenatal visit, 14 weeks, fasting is 114, HbA1c 6.1, it is early GDM. 33-year lady with 75 gram of glucose, fasting 115, 1 hour 231, 207, it is a case of overt diabetes. This is how we label the patient and then we can treat accordingly. So prompt detection and treatment, it improves your everything. It decreases your preeclampsia, reduces your rate of shoulder dystocia, reduces the birth weight, macrosomic risk, and reduces your birth defects also. So management is by MNT, that is medical nutritional therapy, insulins, and with the OADs, again big question mark. And our target is keep your fasting less than 95, 2 hour post meal, whether it's breakfast, lunch or dinner, to be less than 120. Simple. Then there is a role of CGMS also in pregnancy to decrease lower A1C and to decrease the chances of the hypoglycemia. And I am just going to the target. Target is 63 to 140, which we have to keep in that range rather than 70 to 180, which we usually do in our non-pregnant or in a type 2 diabetic patients. So glycemic control is most important. You can check 7-point scale, that is 3 times pre-meals and post-meals. Check your blood pressure, thyroid functions, look for urinary ACR, fundus and ultrasounds for malabsorption. MNT, which very important, approximately 50% of your calories come from carbs. They say 175 grams. 71 grams close to proteins and 28 grams of fats. less of, so 28 grams of fibers, and among the fats you take monounsaturated or polyunsaturated rather than the saturated fats. Don't eat for two. Remember one thing, do physical activities 10 to 15 minutes after every meal, which is most important. And there are papers and papers on the physical activities in diabetes. And when to consider pharmacotherapy, 90% of GDM patients are able to achieve targets with your lifestyle modification. Otherwise, you start with the insulin therapy. So this is the guidelines. When you start insulin, if the fasting is more than 126 and 2 hour post meal is more than 200 along with the MNT. So insulin, we know that basal bolus is the main, where we give 3 shots of bolus insulin before every meal and 1 shot of basal insulin at the bedtime. And these are the, usually I think most of the people, we know how to give and how to check your sugars accordingly. Counseling, I think if you counsel, if you educate your patient well, you will be able to take care each and every aspect of the gestational diabetes. No role of glyburide much, because of main concern is neonatal hypoglycemia, macrosemia and higher birth weight. A word about metformin. Lot of papers are there. Some papers they say safe, some papers they say not safe. But our guidelines say, if you want to give metformin after 20 weeks of pregnancy, not before 20 weeks of pregnancy. If lady is having PCOS already on metformin, you can continue with the metformin in that case. But metformin is not going to help you in decreasing the chances of miscarriages, number one. But there are papers, this is a recent paper which was published in 2024. They say if you have given even metformin along with the insulin, the chances of congenital malformation are slightly on the higher side. So we have to be little safe while prescribing the metformin in all your pregnant females. If you want to give because of so many reasons, then give after 20 weeks of the therapy. And why it causes increased risk is there, because metformin causes decreased vitamin B12 and folic acid level. There is a transplacental exposure to metformin. It will be uptake will be there by the placental. It will impair your mitochondrial respiration, which will decreases your nutrient uptake. It will impair the 1-carbon metabolism, which causes decrease in the gene methylation, and all these things causes defect in the fetal programming. And वो बच्चे who are जिनकी मदर मेटफॉर्मिन ले रही थी, they were little small for gestational age rather than they are macrosomic. And ये जो small for gestational age हैं, if you nurse them, they will be more obese at 9 years of the follow-up. So I think this is fetal monitoring label, and more monitoring is being required. And this is after immediate postpartum. There is a fall in the insulin resistance, and you will require lesser of insulin, and you might not require insulin. And all these ladies should be follow up after 6 weeks or 12 weeks in the postpartum, and you should do the GTT to find out the whether their sugars are now controlled, normal, impaired, or they are being diabetic. So key points, last slide please. Early universal testing for all pregnant females for GDM. Number 1, testing is recommended thrice. First antenatal visit before 12 weeks, 24 to 28 weeks, and 30 to 34 weeks. Single test procedure with 75 gram of glucose to be done. Pregnant female tested positive more than 40 should be started MNT only for 2 weeks. If 2-hour PPG more than 120 after MNT and physical exercise, medical management in the form of insulin or metformin is to be started as per guidelines, and pregnant women are to be monitored by 2-hour postprandial glucose throughout pregnancy as per high risk pregnancy protocols. Pregnant females with GDM on insulin therapy with uncontrolled blood glucose more than 120 usually requires close to 20 units. If they require more, then it is better to shift to the higher institute. Delivery to be done close to 39 weeks, never before 37 weeks, because their lungs are not so much matured. Vaginal delivery is preferred except if there is a fetal macrosomia. Neonatal monitoring of hypoglycemia and other complication is very important. जब भी कोई बच्चा पैदा हो, sugar should be checked within 1 hour after the birth and regularly after 4 hours. If the 4 readings are normal, last 4 readings, if their sugars are more than 45 milligram, then we say this child is not hypoglycemic right now. Thank you for the patient sharing, and thank you taking little extra time, because the chapter is so big and I tried my best to cover the DIPSI guidelines in those 15 minutes.
Thank you very much. But that exceeding of temperature, the time is worthwhile, because diabetes in pregnancy is coming up as a root cause of all non-communicable diseases, being stressed on maternal health for prevention of most of the non-communicable diseases. So this is really important. And I was honored to be one of the framers of DIPSI guidelines in 2006, when first guidelines were proposed. And DIPSI guidelines, I think, are most appropriate in Indian setup. And now the concept is being forwarded as 4th trimester, so that there is no gap between the maternal health before pregnancy and after pregnancy in gestational diabetes.
Sir, और जो ये DIPSI guidelines which was revised in 2023 has been taken by the NICE guidelines.
Yes.
NICE people, like UK people, उन्होंने इसको advocate किया, and the NICE are also following the DIPSI guidelines.
Yes. So thank you very much.
Thank you,
we
sir.
should stress on pre-marriage and preconceptual counseling as, a primordial prevention to all non-communicable diseases.
Thank you,
Thank
sir.
you very much
Thank you, sir.
for enlightening talk.
Thank you, sir. Thank you.